Good afternoon. My name is Vanessa Valcorba, and today I'm going to discuss my quality improvement education program to enhance nurses' knowledge of opioids and confidence assessing opioid-induced sedation. The most commonly used treatment option for both surgical and non-surgical pain management in the hospital setting is opioid analgesics. The literature supports that while opioid use is generally safe for most patients, these medications are commonly associated with the potential for serious adverse drug effects, including sedation, oversedation, and opioid-induced respiratory depression. Nurses can play a major role in preventing life-threatening respiratory depression through sedation assessments that lead to informed decision-making during opioid administration. The Pissarro Opioid-Induced Sedation Scale is strongly recommended by the Joint Commission and the American Society for Pain Management Nursing as being an evidence-based, valid, and reliable tool that clinicians can use to prevent adverse events associated with opioid administration. A needs assessment was conducted at Charlton Memorial Hospital. The Pissarro scale was introduced at South Coast to provide a way for nurses to tie in objective data regarding sedation level and compare it to the patient's self-reported pain intensity score. At Charlton, there continued to be inconsistencies with sedation assessment documentation and treating patients with opioid medications based solely on the patient's pain intensity rating. This can lead to uncontrolled pain and the risk for oversedation. The purpose of this evidence-based quality improvement educational program was to assess nurses' knowledge of the adverse effects of opioids and to assess nurses' confidence with use of the Pissarro scale. The question that provided direction for the project was does providing a nurse-led education program intervention about opioids and the Pissarro Opioid-Induced Sedation Scale change nurses' knowledge of opioids and their confidence in using the Pissarro scale in the acute care setting. The Johns Hopkins evidence-based practice model served as a framework for the project. The Johns Hopkins process is broken down into a 19-step process occurring in 3 phases, which are practice question, evidence, and translation. Referred to as the PEP process, this provided a systematic approach to solving my identified practice problem. The practice theory that guided the educational techniques in the study was the Malcolm S. Knowles adult learning theory. The theory describes 6 assumptions that influence how adults learn best. This practice theory was applicable to the study because the target audience was nurses who fall into the adult learning category, and the information discussed during the education sessions was applicable to their everyday practice as nurses. Charlton Memorial Hospital served as the setting for the study, and it is the 2nd largest South Coast Health Hospital site located in Fall River, Massachusetts. The hospital is made up of multiple inpatient units, but for the purpose of this study, only the staff nurses, resource nurses, and team leaders on ATWA 3 and the cardiovascular step-down unit were considered for inclusion in the study. The study consisted of a pre-test, post-test design. Nurses were educated regarding the adverse effects of opioid use, best practice standards for opioid-induced sedation monitoring, use of the Pissarro scale, and patient factors that increase the risk of excessive sedation. An educational program was developed based on the guidelines set forth by the American Society for Pain Management Nursing and the Joint Commission standards. A total of 14 education sessions was offered over the course of 6 weeks at various dates and times. Each education session was 35 minutes long. The education sessions began by this investigator explaining the purpose of the study and obtaining implied consent. Participation in the study was voluntary. Consented participants received a packet containing their demographic data sheet, pre-intervention opioid knowledge self-assessment, and pre-intervention confidence survey. Participants were asked to identify a unique 4-digit code that would only be known to the participant and to write this 4-digit code on their data collection instruments. The evidence-based education session consisted of a PowerPoint presentation and discussion. Once the discussion was over and all questions were answered, the post-intervention opioid knowledge self-assessment and post-intervention confidence surveys were distributed. These are some of the key personnel and stakeholders for the project. Key personnel include the managers of ATWA 3 and CV step-down, the site mentor, staff nurses on the units, and the inpatient opioid management task force. Approval was obtained from the University of Massachusetts Dartmouth IRB. Approval to conduct the study was also obtained from the nurse managers on the nursing units. All staff registered nurses on ATWA 3 and the cardiovascular step-down unit were encouraged to attend the education sessions. However, it was made clear that there was no obligation for the nurses to participate in the study. Implied consent was obtained and confidentiality was maintained through the use of a unique 4-digit code. In order to provide consent, the participants were of legal consenting age and not considered a vulnerable population. This was a low-risk study, and participation in the study was voluntary. Participants were able to opt out of the study at any time. Some of the highlights for the demographic data include a total of 31 nursing participants, 100% of which were female. Their ages range from 21 to 61. Of the 31 participants, 48.4% worked full-time and 48.4% worked part-time. Of the 31 participants, 64.5% had their bachelor's degrees. Their years of nursing experience ranged from 3 months to 39 years, and 71% of participants had previously been exposed to the Pissarro scale prior to the education session. Pre and post tests were graded and given a total score out of a possible 100 points. The aggregate median score of the pre-knowledge test was 50. Aggregate median score of the post-knowledge test was 80. The assumption of normality was not met for the knowledge test scores, therefore a non-parametric Wilcoxon-Sign ring test was used to compare nursing knowledge pre and post the education session. The test revealed a statistically significant result with a p-value less than 0.001 and a large effect size of 0.62. For confidence, all 31 participants were evaluated on their confidence in sedation assessment in utilizing the Pissarro Opioid Induced Sedation Scale in the acute care setting. Responses to 6 4-point Likert statements regarding how nurses perceive their own confidence were obtained and analyzed pre and post intervention. Participant confidence was present when agree and strongly agree were selected. Lack of participant confidence was present when disagree and strongly disagree were selected. The table illustrates the pre-intervention responses in percentages. This table represents the post-intervention responses to all 6 statements, and as you can see, all participants selected either agree or strongly disagree or strongly agree for all statements. The non-parametric Wilcoxon-Sign ring test was used to compare each confidence statement before and after the education intervention. The test revealed a statistically significant result with a p-value less than 0.001 and a large effect size of 0.56. To prevent a type 1 error from occurring, a Bonferroni correction of aggregate confidence scores was done with a new p-value of 0.008. Even with the new p-value, the comparison of confidence questions revealed a statistically significant change in all 6 statements. 3 open-ended questions were also asked to evaluate the effectiveness of the education intervention. The first question, what did you find most beneficial about this education session? Some of the themes that emerged were it was beneficial to learn this information to apply it to their practice and educate patients. They learned the importance of assessing patients prior to opioid administration and recognizing early signs of sedation. And the education helped reinforce previously learned education and was relevant to work environment and patient population. For the question, how did the format of this educational session help increase your confidence in using the Pissarro scale to assess for unintended sedation in the acute care adult patient? Some of the themes that emerged where the presentation was organized and easy to understand, and administering pre and post tests helped reinforce learning. The last open-ended question asked if the length of the education session was appropriate to review the program's intended objectives, and 100% of the participants commented that the length of the education session was appropriate. Based on this study's results, nurses gained increased knowledge and confidence regarding opioid use and sedation monitoring practices utilizing the Pissarro scale. Of note, the aggregate median score of the pre-knowledge test was 50 and the aggregate mean score of the post-knowledge test was 80. This was a 60% increase between the 2 scores. Responses to the questions on the opioid knowledge self-assessment also demonstrated clinical significance. An example of this is question 2, which asked participants to select the most important predictor of respiratory depression in patients receiving IV opioid analgesics in the hospital setting. Prior to the education session, 6.5% of participants answered the question correctly. However, post-education intervention, 100% of participants answered the question correctly. This result is clinically significant because it is one of the key educational points and addresses the central theme of the project. For the confidence assessment, the greatest percentage of increase in scores was observed with confidence statements 3, 5, and 6. Where nurses feel confident recognizing when to notify a provider to adjust opioid medication dosing based on their assessment findings, they are contributing to a safe plan of care and ultimately helping to prevent adverse events related to opioid use. This study was successfully implemented and contributed to the existing literature regarding nurses' knowledge of opioids and confidence using the Pissarro in the acute care adult patient. Facilitators for the project included nurses' engagement and willingness to learn, scheduling education sessions ahead of time. Nursing leadership support and mentor support were instrumental to assisting with recruitment. The feedback from nursing staff about the education sessions were positive and encouraging. Some direct quotes taken from the post-confidence assessment tool include the presentation kept me engaged and helped enhance my knowledge of opioids. This was helpful to review information about opioids because this medication is frequently given on our unit, and I did not understand the Pissarro prior to this presentation and can now use the information to better assess my patients. barriers included recruitment of participants and staff resistance, which were all anticipated barriers. Limitations included researcher-developed pre- and post-confidence assessment tools, time constraints, format of the test questions, and convenient sampling. Some recommendations include auditing practices to help ensure sustainability. The literature supports that it is crucial to conduct frequent chart audits to ensure compliance with sedation assessment, documentation, and increasing sustainability efforts. Documentation associated with the PSARO should be monitored closely by the leadership teams on the individual nursing units to audit for compliance and improve sustainability at South Coast. The information provided during the education session could be disseminated to other nursing units throughout the South Coast Health Organization, as well as incorporated into hospital orientation. The educational PowerPoint and test questions could be uploaded as an online education learning module and assigned as yearly learning for all nursing staff members. Conducting this study over a longer period of time to assess for increased compliance with using the PSARO and adherence to the practice change, and replicating this study with a different population of nurses to evaluate the response of outcomes would be beneficial. These are my references. And thank you all very much for listening.